Let's talk about blood pressure. Blood pressure is the amount of hydrostatic pressure inside of your arteries, particularly we measure it at the major arteries. Blood pressure is pushing out against the structure of the wall of the artery. And arteries are designed to be both strong to be able to withstand that pressure, but also are designed to be stretchy. The stretchiness of the walls of our arteries makes it easier for our heart to do their job. Imagine if you were trying to push something very quickly into a metal pipe, right? Then imagine what amount of effort it might take to push, I don't know, the world's biggest teddy bear into a metal pipe, right? Now, imagine if instead of a metal pipe, that pipe was made out of something stretchy, like rubber. It'd be easier to do, right? Depending on the size of the bear and all that. So that's what your heart needs to do every time it pushes a burst of blood out of a ventricle. It's like trying to stuff a teddy bear into a pipe. If that pipe is very stretchy, like it's made out of rubber, it's much easier for the heart to do its job. The stretchiness of our arteries is one measure of our heart health. If we take good care of our arteries and of our heart by watching what we eat and exercising, then it makes it easier for our heart to do its job, and we're less likely to end up with a worn out heart and heart failure. So the importance of the elasticity of our arteries, that's the importance of the stretchiness of our arteries. When our arteries are damaged by atherosclerosis or another problem, arteriosclerosis, then they get less stretchy, then it's harder for our heart to do its job. Our blood pressure tends to rise as we get older, and that's not, it is normal, but it's not a sign of heart health. If your arteries stay in healthier condition, then even as you get older, your blood pressure will not necessarily rise. What are the three physiological parameters that dictate what your blood pressure is? Those three parameters are cardiac output, right? And cardiac output, that is how much blood per beat and how many beats per minute, right? Then there is the total volume of the blood. The more blood you have stuffed into your set of blood vessels, the higher your blood pressure will be, with everything else being the same. And then the parameter of vascular resistance. How big are your arteries? How small are your arteries? Now, when we say that these are the three parameters that will dictate your blood pressure, we are also indicating that these are the three different pressure points that can be modulated by your physiology in order to keep your blood pressure under control. Let's think about someone who's got high blood pressure. If someone has high blood pressure, then when I'm trying to bring their blood pressure back down into the normal level, I could decrease their blood volume by giving them a diuretic so that they would pee out more water. That water ultimately comes from blood volume. I could give them a medication that asks their heart to beat more slowly and not as hard to decrease their ejection fraction. Or I could give them a medication that causes their arteries and blood vessels to relax a little bit. Each of those three parameters would allow me as the physician to decrease their blood pressure if it's too high. Let's look at the flip side of that, all right? If a patient has low blood pressure because they have lost a lot of blood, their blood volume is too low, then how would their body try to modulate things so that the body could bring the blood pressure up into the normal range? And one way is by increasing cardiac output. We already talked about this, didn't we? When a person is losing blood internally, you won't notice that they're bleeding if they're bleeding into their abdomen. But even though they're just resting quietly, their cardiac output will, the body will increase their cardiac output to try to compensate for the loss of blood volume if they're bleeding internally. And that's what makes a patient's heart rate go up as they're bleeding, because their body is trying to bring their blood pressure back into the sweet spot. So let's talk about the third part, vascular resistance. I simplified vascular resistance as being changing the radius or the diameter of the blood vessels. If blood vessels are this big and I give the patient a medication to make their blood vessels this big, then I have decreased the radius of their blood pressure, and that will increase their blood pressure. I think I said that wrong. Let me try it again. If I take the blood vessels that are this big in my patient and I cause them to vasoconstrict, then I will decrease the radius of their blood vessels, and that will increase their blood pressure. Decreasing and increasing the radius of blood vessels is a very quick and very powerful way to change a patient's blood pressure. So when a patient comes into the hospital in shock, when we give them a drug like epinephrine, one of the things that it will do is decrease the radius of the blood pressure. When it comes to vascular resistance, this is the most adjustable of these three variables. The viscosity of the blood is not very adjustable, right? However, it is technically a part of vascular resistance. If you have a patient who is very anemic, their blood viscosity is very low. If you have a patient with emphysema who has too many red blood cells per drop of blood, then their blood viscosity is very high. But that's not something we can quickly adjust. It certainly is something that we keep in mind, particularly if a patient's very anemic or has emphysema. The length of blood vessels. You might say, how do we change the length of blood vessels? Well, technically, blood vessels don't change. They don't suddenly grow or get shorter. That's not something that happens. However, every time your body opens up an extra capillary bed, then technically we are increasing the vessel length. When a patient has anaphylactic shock, one of the things that happens is suddenly all of the blood vessel space gets much larger because lots of capillary beds open simultaneously, and that actually can cause blood pressure to drop. But when we are modulating blood pressure in our patients, or when their body is trying to modulate it itself, the diameter, the radius of blood vessels, making vasoconstriction or vasodilation, this is our most adjustable variable. So blood pressure is the force that blood exerts against the wall of a blood vessel. We generally measure it here at the brachial artery, right here on the arm, but we don't have to. It could be measured on a patient's leg. If a patient's had a serious burn injury so that their arms are burned and we're working on their arms, we can keep track of their blood pressure on their legs, for example. Please remember, and you should have learned this in your lab, that every blood pressure measurement has got two numbers. If your aunt tells you that her blood pressure is 100, you have no idea what that means, because every blood pressure's got two numbers. If your aunt's blood pressure is 100, she either has kind of low blood pressure, if that is her systolic number, or very high blood pressure, if that is her diastolic number. You don't know. Every blood pressure reading has got two numbers. The first number is going to be the systolic pressure. What is the systolic pressure? It is how high does blood pressure go in the arteries when the ventricles have just sent out that burst of blood. All right. The systolic pressure is always the first number, and it is always the higher number. And it's called the systolic pressure because that's how much pressure is in the arteries during ventricular systole, ventricular contraction. Okay. The second number is always the lower number, and it is always the diastolic number because it happens during ventricular diastole. So here would be sort of an average or normal blood pressure, 120/75. Your blood pressure could also be, 110/60. That would be equally normal. The first number is the systolic number. The second number is the diastolic number. Blood pressure is an important measure of stress, particularly stress on the small arteries, but it's actually a measure of stress on all of the arteries. And we're going to be talking about that a little bit more because we're going to be talking about the problem of high blood pressure, the problem of hypertension. I'd like to mention this concept, the mean arterial pressure, or the MAP. The MAP is a number that is particularly significant while patients are under anesthesia, or if your patient has got very low blood pressure because of some other major illness. The mean arterial pressure is a measurement of how is there enough blood pressure just to keep all of the tissues of the body getting adequate blood flow. We don't really think about mean arterial pressure very much when our patient's blood pressure is too high. We normally are thinking about mean arterial pressure when our patient's blood pressure is at the lower end, and mean arterial pressure is one calculation. Now, honestly, fancy modern blood pressure machines generally will calculate the mean arterial pressure for you. But a good, simple mean arterial pressure formula is that it is the diastolic pressure plus 1/3 of the pulse pressure. And the pulse pressure is systolic minus diastolic. Take that, 1/3 of that, and add it to the diastolic pressure. When mean arterial pressure is less than 60, you are not managing to keep that patient's blood pressure high enough to prevent tissue damage. So if you've got a patient in the ICU or in the ER or in your operating room, and if your patient's mean arterial pressure is not staying above 60, then you've got to do something, whether it's giving IV fluids or giving another blood transfusion or giving more of a positive inotropic agent. You need to be doing more to intervene because you're getting tissue damage. So, blood pressure. It used to be that the borderline for high blood pressure was 140/90. That has been modulated within the last 5 years, and now the borderline for high blood pressure is 130/80. That means that we are intervening to control high blood pressure in our patients a little bit earlier than we used to. And that is because high blood pressure is epidemic in all of the industrialized nations, and high blood pressure does kill people. We're going to start off with our discussion of high blood pressure at the beginning of the next video.